to thank the organizing committee and the participants for this opportunity to discuss the subject of the biologic reconstructive surgical techniques for the treatment of pediatric musculoskeletal oncology patients. There are significant advancements recently in the field of prosthetic implant possibilities, including personalized implants, 3D printed implants, elongating extendable implants, and so on. With that in mind, I should be mentioning the fact that the main drawbacks of the prosthetic reconstructive options are emphasized in the pediatric population, including the limited implant survival relative to the long potential patient survival. The relative advancement of the biologic reconstructive techniques for this population are more prominent, and this was the reason that I wanted to focus in this talk about the biologic reconstructive techniques. This recent study from Vienna, Austria, demonstrates some of the limitations of prosthetic reconstructive options. These conclusions are similar to other studies on this subject. They looked into the complication of extendable implants with significant patient numbers and long follow-ups, around 27 years. This is one of the accepted classifications for implant failures. The details are not that important for the discussion this morning, but it should be noted that most common types of failure are mainly the soft tissue complications, like contractures, subluxation, and dislocations of a joint adjacent to the elongating segment, occurring in almost half of the patients, and structural failures of the implant in almost a third of the patients. A graphic presentation of the extrapolation of the cumulative incidence showed that soft tissue and mechanical complications can reach more than half of the cases depending on the patient's survival. They found one extra surgical procedure for every 1 centimeter of lengthening, that is for the complications and lengthening procedures combined. So a significant rate of complications in those surgical options. The surgical procedure for the treatment of musculoskeletal malignancies begins with the resection of the tumor. Today, in more than 90% of the cases, or even 95% of the cases, limb-sparing surgery is done. A lot of effort is focused at preserving the functionality of the limb. For this purpose, preservation of the adjacent joint is crucial. Of course, the oncologic safety of the procedure is the first priority, and if safe margins cannot be achieved, then the aim of joint-sparing surgery or even limb-sparing surgery is abandoned. This is an example for a technique that can be safely used even when the tumor is close to the physis but does not cross it. In these cases, because of the irregular plane of the physis, a transphysial osteotomy's risk of positive margins is very high. This technique was first described by Cañadel from Pamplona, Spain. A gradual destruction by an external fixator is done starting 2 weeks prior to the planned surgery date, until the physis finally gives way and tears between the days 10 to 14. During the surgery, a circumferential detachment of the perichondrium is done, and the epiphysis can be safely preserved. One of the most versatile and powerful reconstructive techniques for these cases, when the epiphysis can be spared, is the free vascularized fibular graft with or without tendon transfers. This is an example of a young Ewing sarcoma patient. The tumor involves the diaphyseal part of the humerus, and the bone edema continues almost to the level of the proximal humeral physis. I have to remind you that this bone edema, actually, if you check it pathologically, we see malignant cells in the bone edema surrounding the tumor. The first stage is the resection. This image shows the surgical field after completion of the resection. The distal osteotomy site is shown here, the radial nerve, the brachial vessels, the median nerve, the musculocutaneous nerve, the biceps muscle, the insertion of the pec major, the deltoid muscle. The proximal osteotomy site is shown here, in this case around 1 centimeter distal to the surgical neck. The short and long heads of the biceps can usually be spared. The brachialis is usually sacrificed and left as margins on the specimen. The next stage would be the reconstructive part. It can be divided into the bony reconstruction and the soft tissue reconstruction. For the bony part, either prosthetic implant or biologic, mainly bone graft to its various types, can be used. For the soft tissue part, the consideration is whether to reconstruct the normal anatomy or to use transfers according to the scenario. For the free vascularized fibular graft option, the graft is usually harvested simultaneously while the resection is done to shorten the operative time without detachment of the vascular pedicle. After the completion of the resection, the grafted fibula is fixed in the resection site and the anastomosis is completed. The image on the left is a few weeks after the surgery, and on the right, a bit more than a year post-op. The diameter difference between the graft and the distal humeral segment that is so significant on the left is completely gone a year later, like you can see here. The same process is demonstrated in the proximal lateral side at the proximal osteotomy site, as shown on the proximal medial side. The diameter of the fibula is almost 1.5 times wider a year later, and this is a non-weight-bearing segment. When we use the fibula to reconstruct the femur by a year, the diameter could be twice as wide as the original fibula because the loads are being transferred through the fibula and not through the fixation plate by 1 year post-op. The most significant functional outcome, shortcoming for this level of osteotomy is the typical external rotation deficiency, a bit similar to inborn brachial plexus injury. This is caused by further shifting of the natural imbalance between the 4 strong internal rotators, that's the pectoralis major, the subscapularis, the teres major, and the latissimus dorsi, and the 2 relatively weak external rotators, the infraspinatus and the teres minor. One classic tendon transfer, the lapiscopo tendon transfer, is an optional treatment in these cases. Teres major and latissimus dorsi, naturally internal rotators, are being transferred posteriorly behind the center of rotation of the joint to act as external rotators. The result is the combined effect of the passive equilibrium point rotated externally and the active function of the muscles. A further modification of this technique can be done by inserting the tendons more cranial on the greater tuberosity to assist the abductors. This is the functional result for this patient about 1 year post-op. This is the abduction. Abduction and external rotation. No loss of internal rotation capacity. And this is external rotation with a bit of cheating with the torso. The free vascularized fibular graft is a very versatile and reliable option. It can be used in a wide variety of situations. For example, when the epiphysis is involved and cannot be spared, the fibular graft could be used as an osteochondral graft, as shown on the left. In younger patients, the fibular head will remodel to become a humeral head. The biceps femoris tendon insertion can be harvested with the fibula and attached to the supraspinatus to assist active abduction. It can also be used when the joint is sacrificed, like the case on the right. The complication rate is relatively low, and most complications are mild. Fractures of the graft, if occurs, unite like a fracture through a healthy bone if the vascular supply is intact. Non-union rate is low. If the graft is intussuscepted to the host bone at the osteotomy site, then non-union practically does not occur. Donor site morbidity is mild, with a flexor hallucis longus flexion contracture being the most common complication, followed by hypoesthesia in the distribution of the deep peroneal nerve. Proximal migration of the lateral malleolus and the valgus deformity of the ankle is avoided by using a syndesmotic screw when less than 5 centimeter length of distal fibula is left. I would like to summarize by saying that the relative advantages of biologic reconstructive techniques are emphasized in the pediatric population. Thank you.